So we all know that urinary tract obstruction, though it looks like a kind of a theoretical subject and may not be many people interested in it, but if you just try to see this subject, we would come to know that this is a very important topic because there are so many patients who actually are cases of neglected urinary tract obstruction, which results in obstructive uropathy and followed by obstructive nephropathy, leading to all kinds of problems, even CKD, and patients are going into uremic issues, and may also result in sepsis and all those features. So I think it's a very important topic, and we need to understand the physiology behind this obstruction to help these patients diagnose and manage. So now I would request Dr. Dharmendra to please invite the presenter and start the presentation.
Good morning, sir. I request Dr. Prashant to start his presentation.
Good morning, respected teachers, seniors, colleagues, and juniors. I am presenting a seminar on pathophysiology of urinary tract obstruction. My moderator, Dr. Dharmendra. Coming to prevalence of urinary tract obstruction, prevalence of hydronephrosis has reported in 3.1% in autopsy series. Until 20 years, there is no difference in prevalence between males and females, whereas it is more prevalent in females in 20 to 60 years, and after 60 years of age, more prevalent in males due to prostate disease. Coming to pathological changes of obstruction, in gross pathological findings, kidneys become enlarged, cystic appearance. There is dilatation of pelvis and ureter with blunting of papillary tips. Cortex becomes edematous and slightly enlarged. There is diffuse thinning of cortex. In microscopic pathological findings, at 48 hours, lymphatic dilation, interstitial edema are seen with preservation of tubules and glomerulus. At 7 days, there is collecting duct and tubular dilatation with widening of Bowman space and cytoplasmic hyalinization. At 12 days, papillary tip necrosis and regional tubular destruction is seen. 16 days, interstitial fibrosis starts. At 3 weeks, there is severe tubular loss in inner cortex with proliferation of fibroblasts and deposition of collagen and extracellular matrix, which subsequently leads to widespread glomerular collapse and tubular atrophy at 5 to 6 weeks. This is a diagram showing glomerulus with sclerosis and hyaluronesis seen in the center of this image. This is a diagram showing tubules demonstrating thyroidization type atrophy in which tubules are round with thin epithelium and colloid-like matter in human. And also mononuclear inflammatory infiltrates can also be seen. Now, metabolic changes. Obstruction leads to a number of changes in metabolic processes. There is shift from oxidative metabolism to anaerobic respiration, resulting in reduction of renal ATP levels. Due to obstruction, there are cellular and molecular changes, which leads to progressive and permanent changes in structure of kidney. Initially, interstitial inflammation starts, which subsequently leads to tubular atrophy and apoptosis, and finally leading to tubulointerstitial fibrosis. During this chain of process, a number of cytokines and growth factors have an important role, notably TGF beta, angiotensin 2, TNF alpha, nuclear factor kappa B, tissue inhibitors of metalloproteinases. Some of these cytokines and growth factors are directly produced from tubular and interstitial cells, while others are generated from infiltrating macrophages. Major mechanism of tubular cell death is apoptosis, and main person behind this is caspase, which are specific proteinases which play an important role along with TNF alpha. There are two distinct pathways of caspase activity leading to apoptosis. In one pathway, it involves activation of membrane death receptors due to TNF alpha binding, and second pathway involves mitochondrial release of pro-apoptotic proteins such as cytochrome C, which result due to intrinsic stress signals. In this process, caspase 3 and 8 are central. Coming to renal functional changes in urinary tract obstruction. Obstructive uropathy affect renal hemodynamic variables like renal blood flow, collecting system pressure, and glomerular filtration. And these changes are also influenced by laterality of obstruction, if it's unilateral or bilateral, if obstruction is persisting or relieved, and also extent with severity of obstruction. The varying hemodynamic patterns depend on vasoactive hormones, which are synthesized and released at different rates, the physical damage to glomerulus and tubular units, and renal compensatory mechanisms. It has been seen in animal experiments that there is a triphasic pattern of renal blood flow and urethral pressure changes in unilateral obstruction that differs in bilateral obstruction. This is a diagram summing up the functional changes during urethral obstruction. In unilateral ureteric obstruction, initially there is increased in intratubular pressure, which tries to decrease GFR, which for it kidney compensates by increasing renal blood flow by decreasing afferent arteriolar resistance. These changes are mediated by increase in vasodilators like nitric oxide and prostaglandin E2. So overall, the GFR more or less remains same during the initial phase of 1 to 2 hours. During the next phase of 2 to 5 hours, renal blood flow persistently decreases due to increase in afferent arteriolar resistance, resulting in decrease in GFR, and intratubular pressure remains elevated. During the next late phase, intratubular pressure also decreases along with decrease in renal blood flow and ultimately decrease in GFR. In case of bilateral ureteral obstruction or obstruction of a solitary functioning kidney, initially there is a modest increase in renal blood flow for around 60 to 90 minutes, followed by decrease in renal blood flow. There is increase in intratubular pressure, whole of this process leading to decrease in GFR. The changes in bilateral obstruction are mediated by increased atrial natriuretic peptide. During further course, intratubular pressure remains elevated and renal blood flow persistently decreases, thereby decrease in GFR. Now, effect of obstruction on tubular function. Regarding urinary concentrating ability, normal urine concentrating ability requires maintenance of a hypertonic medullary interstitial gradient, which is achieved by active salt reabsorption from thick ascending limb of loop of Henle, and also water permeability of collecting duct mediated by aquaporin water channels. Obstructive nephropathy can disrupt some or all of these mechanisms, thereby hampering urinary concentrating ability. There might be some associated factors also which disrupt urinary concentrating ability, like development of vasopressin resistance, some vascular changes or decrease in inner medullary plasma flow leading to ischemia, and also dysregulation of aquaporin water channels. Coming to sodium transport decreases due to downregulation of sodium transporters. Due to obstruction, sodium delivery to apical cell membrane slows down. It results in reduction in transmembrane gradient. So there is reduced active sodium transport across basolateral cell membrane. This decrease in sodium transport also contributes to concentrating defect found in obstruction. Obstruction also leads to increased production of prostaglandin E2, which produce natriuresis by inhibiting sodium reabsorption in collecting duct, and it also reduces amount of sodium potassium ATPase as basolateral membrane. All of these processes ultimately leads to reduction in sodium transport. Now regarding potassium transport, renal potassium handling depends upon the type of obstruction. After relief of unilateral obstruction, the potassium excretion decreases in proportion to decrease in GFR. Reason being, first there is intrinsic defect in potassium secretion, and another is due to reduced delivery of sodium to distal nephron, the transmembrane gradient for potassium secretion decreases, thereby decrease in potassium transport after relief of unilateral obstruction. But in case of relief of bilateral urinary obstruction, potassium excretion increases parallel with sodium excretion. It is in this proximal reabsorption, potassium remains unchanged, but secretion in collecting duct is increased, and also massive increase in sodium and water delivery to collecting duct act as stimulus to secrete excess potassium. And also in case of bilateral uretic obstruction, due to volume overload, there is high level of atrial natriuretic peptide, and this high level of ANP stimulate potassium secretion in distal nephrons. Now, regarding urinary acidification, obstruction leads to deficit in urinary acidification. Mainly, acidification defect is in the distal nephron. The causes for lack of acidification are defects in hydrogen ATPase, defect in chloride and bicarbonate exchange. There is back leak of protons into renal interstitium, thereby it leads to failure to generate satisfactory transluminal electrical gradient. All of these process leads to decrease in hydrogen ion transport and ultimately deficit in urinary acidification. After release of unilateral obstruction, phosphate excretion decreases. But in case of relief of bilateral obstruction, phosphate excretion is increased in proportion to sodium. Regarding magnesium excretion, be it unilateral obstruction or bilateral obstruction, after release of obstruction, magnesium excretion is increased due to downregulation of receptors. Now, clinical impact of renal obstruction. It may lead to hypertension and also compensatory renal growth in the unobstructed kidney. Hypertension, it is more common in bilateral obstruction as compared to unilateral obstruction. In bilateral urinary ureteral obstruction, it is volume mediated due to increased intravascular volume. But in unilateral obstruction, the mechanism is different. It is hypertension is due to renin-angiotensin mediation. And hypertension is more likely to be reversed in bilateral obstruction after relief of its obstruction and compensatory renal growth. Regarding compensatory renal growth of unobstructed 43, there is hypertrophy rather than hyperplasia in compensatory renal growth. Compensatory renal growth is influenced by age of the patient being less in older age, degree of obstruction being more in lesser degree of obstruction, and duration of obstruction also affect the compensatory renal growth, with lesser duration of obstruction having more compensatory renal growth in unobstructed kidney. Important mediator in compensatory renal growth is insulin-like growth factor 1. After the obstruction relief, there is renal recovery. It depends on the duration of obstruction. If acute complete ureteral obstruction is promptly relieved, then GFR is fully recovered. If there is long period of complete ureteral obstruction, it results in diminished return of GFR. In canine model, it has been seen that after relief of obstruction, if obstruction is relieved within 7 days, then full recovery of GFR has been seen. After 2 weeks, 70% recovery. After 4 weeks, 30% recovery, and no recovery has been seen after 6 weeks of obstruction. Factors having positive influence on functional recovery are if obstruction is of lesser degree, obstruction is of short duration, and patient is of younger age. And factors which diminish recovery of renal function is older age or decreased renal cortical thickness. Now, few words about post-obstructive diuresis. It is period of significant polyuria that follows the relief of urinary tract obstruction. Urine output can be 200 ml per hour or greater. It mainly occurs after relief of bilateral obstruction or obstruction of a solitary kidney, but it can rarely occur when there is a normal contralateral kidney. It is of two types, physiological, pathological. Coming to physiological post-obstructive diuresis, it is normal physiological response to the volume expansion and volume accumulation during obstruction. Sodium, urea, and free water which are accumulated are eliminated in this type of obstructive post-obstructive diuresis. And after solute and fluid homeostasis is achieved, diuresis subsides. Now, pathological post-obstructive diuresis. It is due to inappropriate renal handling of water and solutes. During obstruction, there is downregulation of sodium transporters with subsequent impaired sodium reabsorption in thick ascending limb of loop of Henle, which prevents maintenance of medullary interstitial gradient required for maintaining urinary concentrating ability. So this leads to continued diuresis. Also, there is increased production and altered regulation of atrial natriuretic peptide, which also induce saline diuresis. It has been seen then there is down regulation of aquaporin water channels, and also there is poor responsiveness of collecting duct to antidiuretic hormone. All this leads to pathological post-obstructive diuresis. So coming to clinical management, majority of patients do not demonstrate clinically significant post-obstructive diuresis. Susceptible ones are those who have signs of fluid overload like edema, hypertension, or congestive heart failure. In management, we have to monitor vitals, serum electrolytes, urea creatinine, and urine output. The intensity of monitoring depends upon the mental status of the patient, renal function status, electrolyte status, and presence of fluid overload signs. If there are signs of obstructive diuresis, but patient is alert, renal functions are normal with normal electrolytes, patient is allowed to able to consume fluids with and observation is continued. If there are signs of hypovolemia, azotemia, or poor cognitive function, then intense monitoring should be done with regular monitoring of vital signs and urine output and electrolytes with urea and creatinine. And in this case, electrolyte and fluid replacement may be required. Fluid replacement in form of 0.45% normal saline initially. Now, some drug therapy which are in experimental phase for post-obstructive diuresis like COX-2 inhibitor and phosphodiesterase type 5 inhibitor, sildenafil. The rationale behind these experimental drugs are that ureteral obstruction leads to increased expression of COX-2 in collecting ducts, and COX-2 downregulates aquaporin 2 channels, thereby inhibiting permeability of water and producing diuresis. So COX-2 inhibitors help in reducing post-obstructive diuresis. And phosphodiesterase 5 inhibitor, sildenafil, it by activating cyclic GMP-mediated pathway, facilitate accumulation of aquaporin 2 channels, thereby helping in reducing diuresis. Thank you.
So Any one of you, if you have any queries, any doubt in mind, just let us know. If anybody from those who are online want to ask any question, just let us know. Okay, so the basic thing is, when we deal with pathophysiology of urinary tract obstruction, what Prashant has dealt with is mainly the upper urinary tract obstruction. So when we are dealing pathophysiology of urinary tract obstruction, you need to discuss the lower tract obstruction also, because the lower urinary tract obstruction in the form of any obstruction at the level of urethra, prostate, and all that will result in many other changes in urethra, in bladder, in the ureters, and then into the kidneys, right? So this has to be kept in mind, that this can also result in problems in bladder also. Right? So the urinary tract obstruction, as we know, the prevalence would be bimodal, because either it is due to congenital obstructions, which would appear usually during infancy, in the childhood, and they may appear later also. So mainly they would appear during when the child is born, right? And the other most common cause is in elderly, where BPH is the most common cause of urinary tract obstruction, which happens in elderly. So that will result in kind of a bladder outlet obstruction, which results in changes in the bladder also. So a neglected case of bladder outlet obstruction will result in chronic retention, will result in decompensated bladder, which cause either thickened bladder wall. So that is why if it is neglected, the results of any kind of treatment or surgery would be not optimal, right? That is why QRT fails sometimes, because the patient has already gone into a decompensated bladder, where the bladder is not able to contract after relieving the obstruction. So that is an important point. Second, when there is a ureteral obstruction could be due to either lower tract obstruction, or it could be obstructive megaureter, ureterocele, ureteric stricture, iatrogenic causes, trauma. All these can cause also ureteric injury. Even extrinsic causes like colonic endometriosis or urinary endometriosis can cause obstruction. There might be tumors which compress the ureters, can cause obstruction. Even chronic constipation, fecal matter can cause obstruction to the urinary tract and result in problems, right? Similarly, the obstruction could be not only anatomical, it could be functional obstruction also. So we see so many patients in the OPD where they have functional obstruction of the bladder outlet, resulting into neurogenic, neurogenic bladder, or sometimes neurogenic causes resulting in this problem. So we need to think of both anatomical and functional causes of obstruction, which can result in these changes, right? And secondly, again, ureteric, there are changes in the ureter also that we haven't discussed. So either long-term ureteric obstruction can cause not only tortuous and dilated ureters, but they will lose their function also. They will lose their ability to cause propulsion of urine, losing peristaltic activity. And sometimes these ureters itself can cause obstruction because they lose the function of peristalsis, right? So that is again very important. And we all must know that all this obstruction can cause obstructive uropathy initially, which is the back pressure changes in the proximal tract, resulting in dilatation of the ureter, dilatation of the pelvic system, and ultimately dilatation of the intratubular system, tubular collecting tubules, right? And that results in, again, decrease in the glomerular filtration rate because of two main reasons. One is this increase in intratubular pressure is called ischemia, right? Ischemia resulting in some inflammatory changes also would cause some inflammation resulting in fibrosis, and all that causes ischemia resulting in loss of GFR. And then there is a thing called upregulation of the receptors. The AT1 receptors and the angioreceptors gets upregulated initially. and there is an increase in the peristaltic activity. So this increase in peristaltic activity might help in some patients who have partial obstruction, right? It helps in passage of urine and everything. But if there is a complete obstruction, this will cause more damage, right? Because there is a complete obstruction, increased peristalsis will cause more dilatation, more rise in intratubular pressure, more ischemia, more fibrosis, more decrease in GFR, and ultimately, as we all know, histopathologically, we find that there is glomerular fibrosis, there is hyalinization, glomerular sclerosis. All these will result in atrophy of the tubules and the nephrons, which ultimately will cause damage to the kidney, which is a condition called obstructive nephropathy. So many patients will result in ultimately obstructive nephropathy, where the patient, if it is a bilateral cause, can result in uremia, CKD, and all those they progress to, right? So I think this is a very important topic because in the sense we need to diagnose this condition in the beginning so that they do not go into this kind of obstructive uropathy and later followed by obstructive nephropathy, right? So anybody has if any question, please let us know. Otherwise, we will wind up the session. Right. Thank you, everybody. All the residents, all faculty members, and all those who have joined the session today. And have a good day. Thank you.